Welcome back. Heading into the home stretch. Talk about our pop quiz. Hopefully somebody out there got the answer right. What time is the best time to treat a heart attack when your symptoms occur? When do you first get those symptoms? 60 minutes, 90 minutes, or 120 minutes? Well, the best is to get to the emergency room less than 60 minutes. And we plumbers, Bob, have a saying, time is muscle. Getting in early before there's significant and long-lasting permanent damage that occurs to your heart and full recovery is less likely is the best order of success. We were just talking at the break about this, that, I posted that just came over the wire last week on our Facebook site. And again, I urge everybody to sign up and tell their friends to sign up. And every day we'll post at least one tidbit that can be helpful for you and your longevity. It was about how a lot of states are now adopting bringing the patient right from the ambulance. The diagnosis is made in the field with an EKG. It's an acute heart attack. This is the right person. They call right over to the emergency room. The emergency room activates the cath lab team. They're waiting there. The doctor's waiting there. By the time, so they're actually coming down, times from 80-minute average to about 36 minutes. I think that's what I posted. So, again, time is muscle. If you can get in there in 30 minutes, I think the mortality is what? It's like 1% or even less, I believe. And that's an amazing, considering I'm back in the Stone Ages when we just used to give clot busters and have to cross our fingers and pray, 15 years ago. We've come a long way, baby, as it's been said. You want to say something?
Well, yes, time is muscle, and we know all these things, that the quicker that the ambulance gets, in this study, bypassing the emergency room, going straight to the catheterization lab, the problem is people don't recognize their symptoms and seek help soon enough. I think the average person waits an hour and a half before they say, oh, you know what, something's going on, I need to go to the hospital. Again, if you're waiting for the elephant to come sit on your chest, that's the minority of patients. Some people will have that, and you'll recognize that's not a subtle event. But the subtle events can be just as bad and have just as bad a disease and result in just as bad of outcomes. So if you have a change in your symptoms, the shortness of breath when you do stuff, the chest pressure, the chest tightness, back pain, like Carol said, you got to seek help and seek it soon, because time is muscle. The more time you have less blood flow to the heart, the more damage that occurs.
And look, folks, we can, like my friend, we can come in, we can have a little atypical symptom, and we can have a normal EKG and normal blood work, and a lot of things can go wrong from that standpoint. And again, the whole idea is never even getting to that point. Let's hit our fourth final take-home point. So what can you do to diagnose and treat and prevent the event? Both of us in the studio have pretty good certification in this. Myself, I'm a board-certified lipid specialist, and Dr. Kaiser is the co-director of the coronary CAT scan angiogram program at Jersey Shore University Medical Center in Neptune. From my perspective, what we call an expanded lipid test, it's been available since 2003, folks, 7 years already, and it allows doctors to peer into your cholesterol below the levels, which we've talked about, and I'll continue to talk about it, do not necessarily predict life and death. It looks more at the quality of the cholesterol. Some 30 million people each year are told they're low risk, but they're actually truly higher. And likewise, they're told that they're high risk, but they aren't, and yet they were told because they're quote-unquote high risk, they require a lot of unnecessary medications and studies. The labs are called the VAP analysis, VAP, at Quest Lab, and basically we take your blood and we spin it and we spin it and we spin it, and that measures the quality, the particles, and how concentrated they are. Very similar test is called an NMR test, nuclear magnetic resonance spectroscopy, say that fast. But it's a study, basically we take your blood and put it through an MRI. That's done at LabCorp. Both are very good at looking at this particular thing, that this entity of quality, not quantity, and whether or not you're building up blockages in your arteries. So you should ask your doctor specifically if you're a candidate. An example would be a person who has an extensive family history, young, under 65, with multiple first-degree family members, or if you have multiple risk factors and you're young yourself at an early age, high blood pressure, diabetes, you smoked, your cholesterol, even pre-diabetes. We don't call it that anymore, but if you're told, oh, you're going to be a diabetic by your doctor, you got to look at the risks. You're 3 times more likely to develop heart disease, stroke, and die with high blood pressure, elevated waistline, and abnormal cholesterol. We call it metabolic syndrome. I call it the Big Mac attack. We're going to do a whole hour on Big Mac attack. Dr. Kaiser, would you like to comment on the use of these coronary scans?
I think, yeah, there's 2 components to the coronary scans, and one is called a calcium scan, whereas that's just a quick CAT scan of the heart. We pick calcium shines on the CAT scan and the x-rays, and we can calculate up and total up the amount of calcium in the heart arteries, and the higher the score, the higher the risk you have for heart disease. The other is actually the full angiogram, which is a more detailed analysis that actually paints the picture and does an angiogram, a non-invasive angiogram of the heart. From a calcium standpoint, I mean, we can argue back and forth about the calcium versus the NMR. Calcium scanning, and the higher the calcium scan, that is very predictive of future events, maybe even more than lipid analysis. And I would submit that that is a direct measure of the of atherosclerosis in the heart arteries. I mean,
that's plaque.
Yes,
plaque in your arteries.
It's hardening of the arteries. If we do a CAT scan of the heart and I see calcium in the heart arteries, you have coronary disease.
Yeah. For the listeners, we basically scored 0 to 100, 100 to 400, and greater than 400. 0 means 0. 0 gives you 4 years free. We now know this from a 5-year study, about an average of 4 years where you're just not, you can say, I don't have heart disease, I can stand on my head, I can do everything, and I'm not going to get a heart attack. Anything else puts you at risk. Before we finish for today, we can talk a little bit about this again if we have some time, go into the CAT scans more, and we're going to do a whole show again with you and your co-director here in the studio. Next week, is it better to be regular or irregular? The deadly atrial fibrillation, it's more common than you think. Pills, shots, or frying, which is better? So we want you to tune in next week for that one. And so many people have AFib. There's a support group. We're going to see if we can get the moderator for that support group on the Facebook, see if we can get him in the studio along with one of our colleagues in the electrical field. We say there's plumbers, contractors, carpenters, and electricians. So we're going to get one of our electricians that we refer to in Monmouth and Ocean County to come in and share his thoughts and answer your questions. Time's up. Tune in next week on Your Smarter Heart University. Remember, friends, get to it before it gets to you. I'm Dr. Scott Eisenberg, along with Dr. Robert Kaiser. Have a great week. Stay healthy.